Here we're going to talk about Chapter 16, Musculoskeletal Neoplasms. Our chapter objectives are to review the pathophysiology of neoplasms, review the properties of benign and malignant growths, differentiate bone and soft tissue tumors with regards to both benign and malignant properties, and consider physical therapy approaches and rehabilitation frameworks for specific musculoskeletal neoplasms. Neoplasm refers to a new or abnormal growth of cells and is often used interchangeably with tumor, which denotes any swelling or mass of tissue. The types of neoplasms include benign neoplasms, which show no tendency to metastasize. They are non-invasive and typically slow-growing. Malignant neoplasms can be invasive and have the potential to metastasize to other parts of the body. Here you can see the various different classifications of soft tissue and bone tumors. Clinical manifestations of neoplasms include pain. The hallmark of a tumor development typically wakes the patient and is not relieved by time of day or changing positions. Fractures. Sudden onset of severe pain may indicate a pathologic fracture caused by tumor involvement. Other symptoms include swelling, fever, or the presence of a mass. Swelling may be more detectable in soft tissue tumors compared to bone tumors. Physical examination may reveal a mass or signs of an inflammatory response. And metastasis. Common sites for extremity sarcomas to metastasize are the lungs, followed by the liver and other bones. Localization and diagnostic tools for tumors. Tumors commonly develop at the ends of long bones due to high growth and remodeling activity. Café au lait spots not present at birth are associated with conditions like neurofibromatosis. You can see an example of that in the image here. The presence of café au lait spots, skin ulcerations, or specific neurological findings such as foot drop or calf pain may be notable. Plain radiographs are essential for detecting and evaluating skeletal tumors, often discovered incidentally during routine radiographs for associated injuries. Provides crucial information about the tumor's impact on bone. Radionuclide bone scans help locate metastases and assesses tumor activity by radioisotope uptake. Greater uptake indicates a more aggressive tumor. CT scans are most sensitive for detecting pulmonary metastases, provides detailed information about tumor interactions and bone structures. MRIs are valuable for evaluating soft tissue tumors and extent of marrow involvement. They are useful for assessing soft tissue masses outside of bone. Biopsies are essential for definite diagnosis. And laboratory tests complement diagnostic imaging and biopsy for a comprehensive evaluation. This is a great diagram showing the different types of bone neoplasms. Malignant bone tumors defined by their capacity to spread or metastasize to other sites are often aggressively invading and destroying adjacent tissues. Skeletal neoplasms commonly metastasize to lungs via the bloodstream. The diagram of bone anatomy and tumor sites. This shows anatomical division of long bones with the epiphysis, the articular end of the long bones, primarily cartilaginous in growing children, and metaphysis, which is the wider part of the shaft along the bones, and the diaphysis, which is the main shaft of the bone. Common primary bone tumor sites. The diagram illustrates typical sites of common primary bone tumors, highlighting locations within the epiphysis, metaphysis, and diaphysis. Osteoblastoma is a reactive but benign bone lesion, larger than osteoid osteoma, with a tendency to expand. Commonly found in the spine, sacrum, and flat bones, occurs most often in men younger than 30, but can occur at any age. It accounts for only 1 to 2% of all benign bone tumors and is reported in children as young as 2 years old and adults in their 70s. Clinical manifestations include spinal involvement, often affects the pedicles, commonly present with persistent pain that is not relieved by aspirin. It is diagnosed through visible or plain radiographs. Other imaging techniques, especially for spinal lesions, may be necessary for detailed evaluation. Treatment includes curettage, which is scraping to remove the contents of the bone cavity, which is often sufficient for long bone lesions. A wider excision may be recommended due to the tumor's unpredictable nature and high recurrence rate, which is up to 15%. Prognosis: initial treatment cures 90 to 95% of osteoblastomas. Despite careful removal, recurrence occurs in about 10% of cases. Osteochondroma is the most common primary benign neoplasm of bone, accounting for 90% of all benign bone tumors. It is characterized by a continuous osseous outgrowth of bone with a cartilaginous gap. The exact incidence of osteochondroma is unknown. Osteochondromas arise from aberrant epiphyseal development, forming an extension of normal bone capped by cartilage. Osteochondromas are typically asymptomatic but may present as a hard mass detectable for many years. While not painful themselves, they can interfere with surrounding soft tissue, including tendons, nerves, or bursa, and compress blood vessels. Large tumors may restrict joint motion. Some key points: the bone in the outgrowth is continuous from the host bone. The most concerning complication is malignant transformation of osteochondromas, often discovered incidentally due to their asymptomatic nature. Again, osteochondroma is a slow-growing malignant neoplasm that can arise spontaneously or from malignant transformation of a pre-existing benign lesion like osteochondroma or enchondroma. Here you can see primary malignant bone tumors. Metastatic neoplasms are the most common form of a secondary neoplasm. Multiple myeloma is the most common primary neoplasm. There's also osteosarcoma, chondrosarcoma, and Ewig sarcoma. In this chart, you can see malignant bone tumors, including osteosarcoma, Ewig sarcoma, and chondrosarcoma, the age that it's primarily diagnosed, the sex ratio from men to women, common sites, and location within the bone. Osteosarcoma, also known as osteogenic sarcoma, is an aggressive and malignant bone tumor characterized by destructive lesions and abundant sclerosis. The tumor cells produce osteoid, which is unmineralized bone tissue, a key feature in osteosarcoma. Osteosarcoma is the second most common malignant bone tumor, accounting for 15 to 20% of all primary bone tumors. It is more frequent in males, male children, adolescents, and young adults near the age of 30, with peaks during adolescence and another smaller peak in individuals older than 50. Osteosarcomas can be primary or secondary tumors. Certain genetic or acquired conditions increase the risk, such as retinoblastoma, Paget's disease of bone, enchondromatosis, and exposure to ionizing radiation. Osteosarcoma grows rapidly and is locally destructive. It can be osteosclerotic, producing neoplastic bone, or osteolytic, which is eroding bone cortex, leading to pathologic fractures. The tumor can lift the periosteum, forming Codman's triangle, where reactive bone develops. Clinical manifestations include persistent pain lasting weeks to months, joint pain, tenderness and limited range of motion, and swelling in the affected area. It is diagnosed, usually initial evaluation with x-rays to identify bone abnormalities, which is then followed up by CT scans and MRIs to assess the extent of the disease and involvement of surrounding tissues. Biopsy is crucial to determine the histologic type of tumor. Management involves surgical removal of the tumor and any metastases. Chemotherapy is often administered before surgery to shrink the tumor and reduce the risk of spread. Rotationplasty or tibia turn-up procedures may be considered depending on the location and size of the tumor to preserve limb function. These were both discussed during your homework. Ewig sarcoma is a malignant primary tumor that can arise in bone or soft tissue and is non-osteogenic. It is the second most common primary malignant bone tumor in children, adolescents, and young adults, representing about 3% of all pediatric malignancies. Most cases occur in individuals under the age of 20, with approximately new cases diagnosed each year in the United States. Main risk factors include white race, parental occupation with exposure to pesticides, herbicides, and fertilizers, and parental smoking. The tumor is soft and can exhibit hemorrhagic necrosis due to rapid growth and outpacing its blood supply. Cortical bone is affected through Haversian canals, and infiltration of the bone marrow can progress extensively without obvious bone destruction. Radiographically, the tumor can cause layered calcification with an onion skin appearance when it perforates the cortex and elevates the periosteum. Local bone pain is the most common presenting symptom, often following an injury like a sports-related incident. Ewig's sarcoma typically affects long bones, specifically the femur, tibia, fibula, and humerus, pelvis, ribs, scapula, vertebrae, feet, and craniofacial bones. Swelling is present in about 70% of cases, and both pain and swelling progress over time. Cure requires intensive therapy to control local and distant disease. Treatment modalities include chemotherapy, radiation, immunotherapy or biotherapy, embolization, and surgery. Local tumors are highly responsive to high-dose radiation. PTA implications include addressing psychosocial, spiritual, and physical aspects. Consider the occupation, family structure, and age. Early mobilization is also important. Avoiding torsion or high-impact activities. Bone integrity and weight-bearing considerations are also important. Strengthening range of motion, balance, and endurance training. Rehab for amputees, assistive devices, orthoses, wound care and environmental modifications if necessary, and patient and family/caregiver education regarding energy conservation, body mechanics, and possible complications. Common primary soft tissue tumors. These are benign tumors. There is lipoma. It is the most common soft tissue tumor composed of mature fat cells. Typically occurs during middle age and late adulthood. Ganglia arise from a joint capsule or tendon sheath, often found on the dorsal aspect of the wrist, or sometimes on the volar aspect of the wrist and lower extremity. Popliteal cyst, also known as a Baker cyst, which you can see here in this image, is a subtype of a ganglion that often communicates with a joint space, commonly palpated behind the knee in older adults with osteoarthritis. Nerve sheath tumors. There are neurofibromas, which is a tumor of the nerve sheath infiltrating nerves and splaying apart nerve fibers. This can occur as a single lesion or part of neurofibromatosis. Schwannoma, which is a rare tumor arising from the sheath or lining around the peripheral nerves. It contains cells and features of Schwann cells, fibroblast, and perineural cells. Both neurofibromas and schwannomas are benign and can be cured surgically. Note that these benign soft tissue tumors generally exhibit slow growth and can often be managed effectively with surgical intervention. Metastatic tumors. Cancer commonly metastasizes to bone and skeletal involvement, representing the third most common site of metastatic spread, following the lung and liver. Secondary or metastatic neoplasms refer to lesions that originate from other origins in the body. All malignant tumors have the capability to spread to bone, making skeletal metastases the most common neoplasm affecting bone. Metastatic bone neoplasms are more prevalent than primary bone lesions. Approximately half of individuals with cancer, excluding skin cancer, will develop bone metastases during the course of their illness. The primary cancer site can vary, excluding skin cancer. Clinical manifestations include pain, particularly more pronounced at night, fractures due to weakness in the bones, numbness and pain from secondary spinal cord compression or vertebral collapse, respiratory symptoms such as atelectasis, which is a lung collapse, and pneumonia resulting from rib metastases. The pathogenesis includes metastases that can occur via the bloodstream, lymphatic system, or direct extension into adjacent tissues. Pathogenesis involves separation of cancer cells from the primary site, dissemination through the bloodstream, attachment to secondary sites, example bone, and subsequent osteolytic or osteoblastic activity within the bone. Note that bone metastases significantly impact quality of life and require comprehensive management to address symptoms and maintain bone health. Metastatic tumors are often diagnosed through patient history, radiograph, bone scans, biopsy, CTs, and MRIs. The management depends on the location and the extent. Intervention modalities include chemotherapy, biotherapy, and others. PTA implications. The most common sites of bone metastases include the vertebrae, pelvis, femur, and bones of the upper extremities. Exercise conditioning must prioritize bone protection, taking into account the extent of bone involvement. Avoid high-impact activities and activities that involve high torsion, as these can increase the risk of pathologic fractures. Focus on fall prevention strategies and teach proper mobility techniques to mitigate the risk of injury. Encourage early mobilization after procedures to maintain function and prevent complications. Treatment goals should be a collaboration with the healthcare team to restore or improve functional abilities while respecting bone health and minimizing risk of fractures. Implement appropriate exercise programs that promote mobility and function without compromising bone integrity.